And great. And while folks are joining, I'll just, I guess it's a couple minutes after. I will, I guess, make a plug for next month, where I believe we're going to be hearing from our own, I think it's Frank Zhu and Jamie Smith talking about pilot findings. They are a year 4 pilot team. So we'll look forward to hearing from them. And I don't remember, Chase, can maybe you can put in the chat when the seminar is next month so folks can mark their calendars. And today I'm really excited to be able to introduce another one of our year 4 pilot PIs, Dr. Kelly Gleason, who has been funded both by the Hopkins Economics of Alzheimer's Disease and Services Center, as well as the I'm sure I'm going to butcher the name. I know it's the JHAITC. And you want to maybe mention the name of it in full?
Sure, it is a mouthful. It's the Johns Hopkins Artificial Intelligence and Technology Collaboratory.
Great. And so we are really, we're thrilled that we're able to find this intersection between the two centers. And what we're planning to do is first, we will hear from Dr. Gleason, who will present on research completed in progress that relates to her pilot. And then we are going to have some time at the end to hear from Ann Wicker from the JHAITC, so we can hear a little bit more about that center and where there may be some opportunities for folks who are affiliated with the head center. So with that said, I will go ahead and I'm delighted to introduce Kelly Gleason, with whom I've had the great pleasure of working over the last several years. She is an assistant professor at the Johns Hopkins School of Nursing. She led the development of an institution-wide service that leverages the patient portal for research. And she continues to work helping the Hopkins community leverage the electronic medical record for research purposes. She serves as the co-lead of the Armstrong Institute's Center for Diagnostic Excellence core, and she leads a national nurse and diagnoses community of practice. Her research that she'll be presenting on today talks about patient portal messaging and opportunity to identify and support care partners of persons with dementia. And so, Kelly, why don't you take it away? We are, I believe, looking forward to making this interactive so that Kelly will first present on her ideas, and then I think look forward to feedback from the community. But go ahead, Kelly, and take it away.
And I'm so steeped in this right now that please don't hesitate to jump in with questions at any time, because there's things that I think about so often that I forget that, you know, it's not every day for. So anyways, jump in with questions. I'm very excited to present on patient portal messages to identify and support care partners, persons with dementia. Dr. Wolf largely covered my acknowledgements, but I did want to say that a lot of this initial foundation of this work was made possible by Dr. Wolf's R35. And so just know that, you know, it took a lot more resources than what we so do not, you know, there's a data analyst, a statistician, a big team involved in making a lot of the initial findings possible. So background, why use portal messaging to identify and support care partners of persons with dementia? And I'm going to take a while on this background because I really think it's important that we dispel some of the common preconceived notions about patient portals and older adults. I know that from being in the patient portal space for a while, it was very commonly thought of that the second you say portal, you're excluding older adults and those with cognitive impairment. So, and another reason why this is important is that patient portal messaging is really rapidly growing, and it's straining a very overwhelmed primary care system. And that's really who's on the receiving end of the high majority of these messages is primary care. You know, it's not going to, most of these messages aren't going to a memory care clinic specialist. in dementia care, they're going to a primary care physician where that person with dementia is a small fraction of a very large panel of patients with many different conditions. So having the different resources and care specific to persons with dementia is not always right top of mind. So to understand portal use by persons with dementia and their care partners, we developed a large electronic health record-based data set. We required 2 appointments within a 24-month period for adults over the age of 65. And the reason for the 2 appointments was that while missing data in electronic health records is unavoidable no matter what your criteria is, we did want to make sure that there was at least enough appointments that that diagnoses they had would be captured and other major characteristics of other health. In addition to some standard data elements when you're working with EHR data, we also collected patient portal activity and patient portal messages, which allowed us to dig into this issue. So first, I want to show older adults portal use by dementia diagnosis. The navy blue bars you see are the persons with dementia. So you can see that for registered accounts, it was very similar. And for active, we defined active as that you logged on sometime within the 5 years. Also very similar. The only place you see a difference was a care partner registered as a shared access user, when about 3 times the number of shared access users were seen for persons with dementia than not. We then looked at it by time of diagnosis to see how you might have changed before and after your dementia diagnosis. The gray line is number of sessions, so that's logging on and conducting at least one other activity than logging on. The orange line is number of messages sent per month by this patient population. And then the blue line is the activity metric. And so that's how many sessions you had divided by how many encounters you had. So it takes into account the fact that the number of visits you've had might have increased once you received that diagnosis. And what you can see across the board is that there's an increase after the time of dementia diagnosis, which we can't say for sure, but kind of indicates that there might be some leaning on the extra resources provided by the portal after the diagnosis. When we looked at shared access use in particular, shared access is having your own separate logon credentials to get to a patient's account. As an example, for my 2 kids, I have shared access use to their patient portals where I am not logging on as if I'm the child. I'm logging on as Kelly Gleason, their mother, and all the activity and messages I send reflect the fact that I'm the mother. And the same is possible for any adult patient if they have a shared access user. What we see, again, blue line persons with dementia, is that the shared access use was more common. The second panel is the activity metric. So we see, even if we zoom in among just shared access users, that persons with dementia, their shared access users are a little bit more active. But then, we also saw by analyzing message text that the use is most often happening not through shared access credentials. So when we looked at message text, I have 970 threads. That's because versus individual messages, it made more sense to look at threads, so the first message of a back and forth conversation, because you're very likely to introduce yourself fully in that first message to clinical staff, but you're not going to introduce yourself fully each time, which is a reason for threads. What we saw is that a very, very small number, like less than 3%, came from an actual shared access account. But if we looked at the content of the messages, and this is people, introducing themselves, this is not us having some other sneaky way to identify it. We saw that almost 2/3 were sent by a care partner, indicating that the use is likely really happening more by the care partner. And I want to make sure we put out there, care partners using patient credentials versus shared access credentials is very understandable and very common. I'll get to the very common part next, but it is not easy to get a shared access account if you do not already have a patient portal account at that health system. If you're a Hopkins patient already, getting your kids signed up as yours and already using that with being able to toggle between the two is easy. but getting a new portal account for a non-patient who's just using it as a shared access user, there are barriers that we want to recognize. And we also there's widespread lack of awareness and really an emphasis on its importance. However, it's only being used more and more to collect really sensitive information that's guiding healthcare decisions. Pre-visit questionnaires that are then used to base referrals on, and like how to target for concerns, messages, legal documents, health documents. It's becoming increasingly important that we do know who's filling those out and that there is transparency in the use.
Kelly, before you move on, there's a question in the chat.
Mhm.
Elizabeth, I don't know if you want to ask the question.
Oh, sure. Yeah, it's Elizabeth Phelan. Good morning. I was curious what your approach was to identifying the group of people who had dementia. What criteria did you use? I might have missed that. Sorry if I
We
did.
use so we adapted the Gradstein method, which I think is commonly thought of as the Bynum method, where it had to be documented at least twice, more than 7 days apart. If it was the ICD-10 code, if it was documented on the problem list, then we only required once. And Liz, if you are interested, I can send you the full explanation of how we adapted the Gradstein method.
That'd be great. Yeah, thank you. Thanks.
We conducted 2 scoping reviews to see what this looked like by others who have done it, but then also published on it. And what we found is that this finding of shared access use across all patient populations is very low, but use through patient credentials by message analysis is high. And we found that it was most likely among patients who needed help navigating the healthcare system. Examples including non-English speakers were more likely to have a child who was using the patient portal on their behalf. And we saw in the qualitative studies that looked at it that care partners and patients were really supportive and voiced the benefits towards it. We also conducted one of patient portal interventions, and the funny thing about it is that this reason why we went back to conduct this big review on patient portal interventions was that we really wanted to see, were there any that specifically looked at care partners or formally included care partners, and were there any that looked at persons with cognitive impairment or really any other disability, and there weren't. This is really just a not touched area, and I just can't help but wonder how much of it is because of this kind of preconceived notion that the second you're saying anything electronic, it's just not going to work for older adults or those with cognitive impairment. So building on this background, we proposed to build SmartRep. And that's where the idea that when a message comes in from persons with dementia or other care partners, we can apply AI that's co-designed by care partners, geriatricians, other allied health professionals focused on persons with dementia to help create some content to draft the message with focusing on non-acute concerns in particular. So questions about falls and safety. I know that falls can be acute, but we see questions that are like, how do I make I'm building an in-law suite. How do we make it safe? And part of this is to just ensure that care partners are recognized and documented, and that reducing clinician workload, particularly those working in settings where persons with dementia are a very small fraction, so they don't have these resources top of mind, while still increasing the quality of the messages received would be the goal. So an example, message sent from Lisa's patient portal account, no identified care partner. And I just really want to emphasize, when there's no care partner identified anywhere in the electronic health record or who that care partner currently is, let's say that there's a wandering incident and that patient ends up in the emergency department, that even though it's very well known between the primary care staff and the patient that she always comes in with Martha, her care partner, that ED physician has no idea who that person is or how to reach and contact them about this. They've gotten the name, they've gotten this, but they can't. So this is a concern that we hear about often. And it's just widely recognized as an issue. So processed by SmartRep, they captured, okay, there was a fall. I don't have it highlighted, but there's no injuries, so this doesn't seem to be acute at this moment. Tripped over a rug, maybe an environmental issue. And then it shows that it's probably from a care partner based off of the language used. And they can send resources, including, and I know that the Baby Call to Care is not as active right now, but as an example, there's local programs like the Call to Care one that are really to help caregivers of persons with dementia. For falls, the ones that that physicians who commonly work with these patients really love and think are great. We can make sure it's those. And then also offer instruction on how a care partner can register for shared access and deliver a questionnaire that matches Epic's patient context form. So I'll get into that. This is the lay caregiver context form in Epic. I have a screenshot of my own lay caregiver's contact form in Epic. It's not fully accurate. It was done, I don't know, must have been done years and years ago. It's very, very sparsely used and populated. It's a little bit more so for persons with dementia, but I would say like 80% of patients don't have something here. And it would be very easy to build this into, or not very easy, but something that we could do to make sure that we do know who's taking care of persons with dementia. And then how can improve shared access? Really, even just sending instructions and saying we highly encourage it could be a big step forward. What we've consistently seen, and we have other work that spans multiple health systems trying to increase shared access registration, is that there's a huge issue around awareness and clinical staff awareness, and also clinical staff time. That even though, and we also I presented to the frontline JHCP primary care panel on this. And they said it's a big issue where, yes, they're supposed to send shared access instructions whenever a non-patient author of a message is detected, but doing that extra step on top of everything else is just adding is adding a load on a really overwhelmed system. And just some ideas of how SmartRep can improve outcomes. Person with wandering, sending wandering resources, just including that in the message draft. Ones again that care partners and other just key allied health professionals really know that they recommend and lean on. So where we are right now is decisions about rule-based and machine learning. And it's funny because when Dr. Wolf was introducing me, I was thinking about when we first started working on this, and it was 2022. And the idea of doing anything AI in portal messages felt so, oh, no health system will ever accept this. This is going to be totally out of the box. But now actually, so that was a big reason for the rule-based idea, where rule-based really allows extremely tight control. Where you can very, very much so constrain the model and what it responds to and what type of responses it generates. But now GPT-4 is increasingly used in Epic. There's a partnership between Microsoft's OpenAI and Epic. And so this is a possibility. And I'll get into that later about how this can actually can really open doors. So I'm first going to do an example with rule-based, and then I'm going to do an example with GPT. So this is just, it's a very sloppy show, but this is our first NLP test run that we ever did, where we tested out words, and we included both patient or proxy senders, shared access senders. So we had an instant gold standard right there of when something was sent by a non-patient. And from doing that to messages of all older adults, we found that about 31% of all patients had a message sent from a care partner. And we didn't do a super rigorous review because, again, this was just our initial kind of like, what would this look like if we did it? But what we did see from gathering through was that it was actually pretty decent. So then we took that, just a few small iterations really, and we created a gold standard to compare it to. So a few of us team members manually labeled a set of messages according to whether or not it was sent by a care partner. And then we ran tests to see its performance, and it was really quickly pretty good. We hardly had to do any changes, which is what the graph reflects between them, which kind of shows that this is a very feasible thing to do. I identify a non-patient author in patient portal messages. This did not take an extremely complex algorithm. It took an algorithm that was really about like 8 to 10 lines of code versus a much longer one. And I have here the, I originally didn't have the notes to the side, and then I realized that AUK is probably not a common acronym for everybody, but the AUK is the area under the receiver operating characteristic curve, also called the ROC, and it demonstrates the performance of a binary classifier. 0.80 generally indicates acceptable level of performance at identifying at the binary classification. And you can see that we exceed 0.8. And again, drawing on limited information, very simple algorithm. And then, what we could do is just automatically trigger a message that doesn't even say, looks like a non-patient author is sending it, but more like an automated message reply that says, they'll respond to your message. We can insert the standard response time. If your message is urgent, insert, protocol for urgent concerns. And state, it really helps us when we know who the person with dementia's care partners, and here are steps so that we can know who you are, of the lay giver questionnaire and the shared access sign up process. And now I'll get into the GPT-4, because this is how I felt for the last, I don't know, like 6 months, like, wow, we're really moving so fast. So GPT-4 generated drafts are now available in the patient portal thanks to Epic and Microsoft's partnership. Many health systems are testing it. Less, it seems, have implemented system-wide. Our main partner in this work, University of Colorado Health, they've rolled it out in their seniors clinics. The GPT-4 drafts, JHCP has rolled it out across several clinics. Again, more in like an early stage feasibility testing place. Pros, and I have a bunch of sites for this if anybody's interested. I just felt like I was overwhelming with because I'm in the writing phase for this. But empathy is actually related as equal or higher than clinician drafted responses. That might be due to length, it's thought. If you've ever used GPT-4 before, you might know, or sorry, not GPT-4, but just even basic GPT, Gemini, they tend to be more verbose than really any of us are, because we don't have that time and energy, but also an overwhelmed clinical staff responding to a message. And then quality, which has been rated in different ways. And these studies, empathy, I think, has been done enough different ways that seems true. But I will say that the quality messages ratings, they were done more to, those studies were done using more like AskDoc in Reddit and different open online forums, where people took those patient questions and they ran it through GPT, and they compared what the physician's top physician's response was to the GPT. A major pro of GPT is that it's insanely widely used and adopted. It's supposed to be one of the most rapidly adopted and used technologies that's like ever been seen. And I don't think that's an exaggeration. An article from over a year ago said that there was more than 180 million active users. Cons, requires a high reading level. Most of them are at least 10th grade. It can be highly inaccurate when it isn't accurate, and deliver that with extreme confidence. I personally have gone down an extremely wrong stats try before, because it gave the potential code so confidently. I was like, I must be the one making the mistake. There's that issue, which is a significant one. And so we mostly know that the Epic, how it's being used in Epic, it's been, because it's so new, we don't know too much on it, but there has been a paper out of Stanford, first authors Garcia, 2024, and they found that even though there was high satisfaction among the clinical staff that was using it, the amount of time it took to send the message and the response time actually did not change with GPT-4. And that kind of matches with the anecdotal evidence I've heard from people who use it, which is that it's helpful to have this starting draft, but you end up spending a lot of time editing it. And so that brings me to prompt engineering and the idea of what would smart rep look like if we used all this coded process of getting feedback from care partners, persons with dementia, all these different experts on what should we ideally be telling the GPT-4, the large language model that's not GPT-4, what should we telling their output ideally looks like? You can define what resources and tools to draw on. You can define what's its scope, where should it not even say it can respond to a message on because it's outside of the scope. What's the desired length? What's the literacy level? What's the tone? It's not perfect, but there have been studies, again, happy to provide references to anybody interested, that show it really improves the quality of LLM responses. People, who use it every single day, a lot of them will start when you're starting on a certain series of questions where you're going to be asking the LLM a lot. You might put in there at the start, here's how I would like you to respond. So, just to give like a light example, that in this question of I want some information to how to help my dad with dementia stay occupied, you can think about things like what type of literacy level would we want with that? What type of length? Should the tone be friendly or professional? Is there a preferred national resource on this issue? Is there a preferred local resource that we would like them to know about? Do we need further information? And do we know that this patient has a child who helps with their care, or do we have no documented lay caregiver, no shared access user? So we have no record that there's somebody who we should call if we have questions about this patient or an emergency happens. So this is using a heavily de-identified example, which I thought was something any of us can relate to just to see the differences. So patient message, my mother's iron is low. Is there any over-the-counter she can do? And this is the de-identified provider's response, which the only way it would be identifiable, I believe, is if you are the physician who drafted it. But please get her started on iron supplements. And if you see, there's all this kind of tough information in here where maybe there's like a close enough relationship between the physician and the care partner that they know that the care partner can quickly grasp. But then, it has in there, she should be on at least 100 milligrams of cholase. So now we're also starting a stool softener. Black stool is a side effect. And again, these messages are not reimbursed. They're done outside of clinical hours. They're done, like, there's so many different things that make it kind of just not the best way to draft a very informative message. Then if you look at the GPT response, and this was done with no prompt engineering guide, you can see that they list a few different over-the-counter options, but they also include foods and how to increase it and substances to avoid. And they have the different recommendations bolded. So that wouldn't be a bad one to start off with if you were a clinician. It might be more information that you wanted to go through. But it could remind you of some things you might want to include. Now, this is extremely rough, and so I want to put in there, don't judge me. It was an extremely, I just wanted a quick example to show in this presentation. So I then asked it, and I said, please respond to further questions at no more than a 3rd grade level. And if somebody's writing on behalf of somebody else, please guide them to register for proxy access using this link. So just using that, you can see that this is like the same GPT. They made the message a lot shorter to deal with. I would imagine that was in response to the literacy level. And then they did have, they did include the proxy access instructions, and they did use them, as I would want them to, but maybe not as much helpful language as I would have wanted inserted about why it was important. So just, already thinking like, okay, the next time that I try to prompt engineer this, do I say, please keep the same length and the same content as was in your original message, but by a 3rd grade reading level. So you need to think about other ways to make the language simpler than just shortening and cutting. And so anyways, that's kind of where we're at. Next steps for Smart Rep development are to gather a bunch of feedback from persons with dementia and their care partners. We plan to interview 50 care partners of persons with dementia and dementia themselves to explore their perceptions on the use of AI to support patient-reported message responses. What are their concerns? What would they want to see? What level of transparency do they want to see? If it's a heavily edited physician response, should it still have text at the bottom saying like this was, partially used by AI? Just to get as much feedback as possible. And, I have some concluding text, but I think that now is a good place to stop for questions.
Wonderful. Thank you. And I see Conan has his hand up and there are a couple of questions in the chat. Conan, do you want to start and then maybe turn to the folks in the chat?
Yeah, so this is really fun. So I appreciate you doing this. I have two questions. One is sort of how do the HIPAA people feel about some of this kind of stuff in terms of, like the fact that you're sort of exposing that people are actually on the account that aren't supposed to be. Like, is there kind of a pushback effect or a potential risk of that? And then second, one thing that would be really interesting is whether or not, to what extent people, once they're sort of advised to go to the link and sign up, like if you capture like what percentage of people actually do that, that would be fun too. This is really interesting. Thank you.
So the HIPAA thing is particularly interesting because the HIPAA applies to the patient. It doesn't apply to the care partner, but we also don't have, like we're also kind of invading the care partner's privacy. Now, the way that I've seen it is or argued it that this is to classify if a non-patient sender was there and then to prompt them to, okay, based off of this, classification, consider taking these steps so that you are formally identified. Now there's other work that says, now you're putting work on the care partner and really we can take what they have and we can populate it into at the very least, some some automatic note that says what their care partner ecosystem might be. And so I'm not a part of I've only recently started meeting with the investigators at UC Health who are doing that specific kind of like let's go ahead and identify this care partner, and not only that, let's label what role each care partner has. So like the message is from Kathy, who does all of the patient portal management for mom, but actually her son and his wife take care of the mom. Like you could take that and pop that into something so that but then you're really getting into like, are we drawing too much on information that's there? So anyways, I guess the answer is that I've bypassed it for now by saying the non-patient classifier. And then the other one is, yes, how many people actually register for shared access is what I want to study. Like, is it, once we start including those instructions, does it actually increase registration, or is it still just so burdensome that nobody does anything? And one idea that we've had, Conan, that we've tried to build into it is if we continue, let's say that you can build it that if they continue messaging, if there continues to be non-patient authors, you say, hey, shared access registration is really hard and we totally understand that. And we have patient navigators who are here to, who are an existing resource at these clinics. And part of what they do is to help with patient portal registration. So we're going to have one of them call you. Let us know if you opt out of that. But that's been a thought for how to bypass this kind of just burdensome process. And I will admit that it's hard just because from like end user testing, so many of us already do have patient portals that we've done a couple different, like there's secret shoppers of what it looks like. But it's hard when I can't replicate it myself, or how hard it must be to get registered. Thank you.
Thank you.
So Deborah has a comment in the chat. Deborah, I don't know if you want to unmute and ask your question.
Sure. Great presentation, by the way. Sorry, my Wi-Fi is unstable, which is why I put it in the chat. But this is really relevant to some of the work that we're trying to do at Kaiser around this area and issue. And I think what's interesting, working in an academic system, but now working with a more integrated system, is just how different their process is for management of this messaging, right? So there's a lot of bypass that goes on. There is a team that's independent of the clinician that gets a message and basically decides, okay, this person needs to come in versus this person needs to get a call from the clinic. And so I think that kind of presents its own unique challenges. And then one thing I will say for us that we found was that the messaging for older adults is different. So when we looked at the actual portal instructions for our clinics, we're giving people instructions on how to set up proxy access, but then we're using a lot of language around children and parents and not reflecting the relationship that older adults can have with their care partners. So I feel like you hit on a bunch of different things, but I'm curious if you've at all thought about this topic from the perspective maybe of like a non-academic health system.
So just the issue that you bring up of how proxy access is typically thought of is particularly relevant when you're working with primary care clinics that are family medicine. So they see everywhere from a 1-year-old to to an 85-year-old that were older when and we found just again, like in the other side, which I didn't bring up, but also a Dr. Wolf-led study, we found that when we tried to increase shared access registration by going through clinical staff and building a human-centered design process to help them give materials to register, that even when we would come and present as that group and we were focused on older adults, they were thinking about it in terms of like, oh, when adolescents hand over their proxy account to parents and how tricky that is, and younger younger than adolescent patients, that it just the issues around older adults are so different that it does require like some separate, and I don't think I've given it as much thought as I need to. So I'm happy that you brought it up as something for me to kind of, because the proxy access instructions we have on most, the general patient portal ones that most health systems have, when you click into them, it does have these 7 different scenarios when you'd want to proxy access users. But really, I think in the ideal world, it's like once somebody turns a certain age, they start thinking about, okay, something might happen to me that I need a shared access user on here. And that content might look just a little bit different than, do I have known, lack of capacity, so I need to get this person. And then in terms of integrated, I think it's Deborah, it's very hard to compare to, I will say that Kaiser, I more just feel extreme jealousy when I hear about Kaiser's processes. Because yes, that does sound wonderful. And we do deal with how to triage messages that they don't even, messages are triaged sometimes that they are first just go immediately to staff and then the physician, but it's very much to that clinic versus being some general health system wide place that triages them. And so I think I would need to look at how often that's that is the case, and at the very least acknowledge the fact that this work is limited to places where it is like the clinic that's receiving the message versus a general centralized place.
Well, you're doing amazing work, so maybe I'll pick your brain after.
Thank you so much. We can learn from each other.
Great. And then Judith Vick had a comment. Judith, do you want to ask your question?
Yeah, sure. As though I think you sort of answered it because you had mentioned something about the bot. So I was asking if recipients knew that it was an AI generated response, and it sounds like maybe there's like something on the bottom indicating that.
So how we were initially doing it, Judith, was that was the idea of like this being almost like a, kind of like how I showed that first one of like the patient before GPT-4 was implemented, the idea of, okay, when a person sends a message, can we just automatically send this that addresses the non-patient author issue? And then later on the, the clinical staff will respond. And that was 100% going to have text saying, this is an automated message that was sent, like, please have this. So that, to me, that seemed like a no-brainer that we would have the automated message. But I think what becomes a lot harder is these AI generated drafts and how to make, like, this has been a physician reviewed AI generated draft. Well, what if the physician spent like 10 minutes and they really only used like the first sentence of it? Will that then change how the person with dementia and care partner perceive the message when and how much the physician actually thought about their specific condition with the response? I think that's where it becomes like ethically a lot trickier to make the decisions. Like, what do you do? Do you transparently share the level of editing that they made, given in track changes? I think that's like a big thing that I want to talk to persons with dementia and their care partners about once I'm able to start that component of it.
Yeah, that's super fascinating. Um, and this is super cool work. I also wonder if AI could help, because my experience, though quite limited, but in primary care settings, is a lot of the messages that come, like your examples were like very good questions. Like they were very clear
Oh,
questions. Like
because yeah,
from
you're right. I was cherry picking the options instead of
right,
showing the
but
general. Yeah.
right. So very often the question is like wound, and it's like what's the question, but I
7
want, and it's very time
paragraphs.
consuming. Yeah, or the
Yeah.
opposite, like paragraphs and paragraphs, and it's like, what are you asking me?
Yeah.
And I wonder if like you could use AI, and it could be very time consuming to like get to what is the question, but you can imagine prompts that could get someone to that quicker, which would be so helpful.
That's a cool idea. The idea of and I think I had them, but like the idea that hey, if a message is only has X amount of information or X amount of words, please respond and ask them like, do you mind expanding on that so we can better respond to your question? And I with
Yeah,
like I'm sure Esther's not on, but I talked about the issue of like the 7 paragraph messages because we see them a lot, and obviously
yeah.
clinicians, they exist. And whether it's something that a GPT should just stay away from and not even try because it's just the definition of, like, let's set up an appointment. But
Hmm,
I don't
hmm.
know. Then I wonder if even having that just automatic thing of like, can we set up a phone call, or this helps relieve the idea like, okay, it's my job to respond to this at 10 p.m. at night so I can clear my inbox. But I think
Yeah.
that's a tricky situation too. Sorry, Judith, I'm just talking out loud versus answering your
No,
questions.
no,
Okay.
no, no. That's awesome. One very last thing, which is anecdotally, like 7 or 8 years ago, I tried to get proxy access for my mom, and I asked every person on the face of the planet, and they all looked at me like they didn't know what they were doing and like what I was talking about. And probably like 2 or 3 years ago, I was very easily able to do it. I mean, I'm not the, I was,
Yeah. But then
it was
the
like on the
other,
website.
this isn't a thing at Hopkins, but at other health systems, they have it that if you are the proxy user of an older adult's account, you don't have access to billing. So I remember talking to one care partner person with dementia when I was trying to get her feedback on this. And she's like, Kelly, of course I don't use shared access. Who do they think is paying, like my 90-year-old dad with severe dementia's bills? She's like, it annoys me so much that I refuse to use it. um,
Obviously
uh,
still problems.
yeah, I think it's interesting. And I think that it's also just important to say, care partners are working so hard and they have so many other things on them that the last thing we would ever want it to come off as is like, you're doing something wrong. Please take 30 more minutes of your time to do this. And so that it just needs to be easier. And, we talked to Epic, Dr. Will, I keep on giving you shout outs, but Dr. Wolf has this very cool collaborative where there's vendors of the different EHRs involved. And the vendors kind of make it seem like, oh, this is a health system problem because they aren't prioritizing it. So we don't need to. It's like there's a lot of like finger pointing kind of. Yeah. But cool that it took only 3 years ago. It was easier than 10 years ago. Woo, progress.
So
And
there's one more question from Elizabeth Phelan, and then I think we probably should turn it over to hear about the AITC. Liz, do you want to ask your question?
Sure. So I was wondering about topics that care partners of persons with dementia might typically write in to request help around. Like the iron example probably is something that would be more likely to be dealt with, like would have been identified in the context of a clinic visit. It's nice and straightforward, obviously, for example purposes, but wondering about, say, for example, the care partner is dealing with, agitated behaviors, combative behaviors, and is seeking help for that. Where does AI pull information from for addressing issues that are more dementia specific? And how reliable would those information sources be?
So I appreciate both you and Judith calling me out for using an easy example for how this could work. And I think that so Elizabeth, I'm talking about even just confining to like so a lot of people, for example, like the Alzheimer's Association has one page that's really, really good. I'm talking about like starting off as that and saying like, this should be where the bulk of your response comes from is this. But if it's extremely severe behaviors, then maybe it isn't something that's addressed by that prompt. Or as an example, like, you know, Quincy Samos's work where that has a nurse come and help the caregivers use behavioral interventions. A lot of times that's not even known about that it exists as a program. You know, could you put something in there in the draft so that the clinician knows like, ooh, this is something I might be able to recommend them to. And so long story short is that it's something that I'm working on over like the next year versus that I have a good answer to now. But these are the types of things that we're thinking of, is like, what are the specific resources that you know, an expert memory clinician like Halima, like where would she have it drawn? So I hope
Wonderful.
that helps, but oops, sorry.
No, I just was going to say, it's just really, this was really lovely to hear the dialogue and the questions around this very timely, fast-moving topic. And so thanks for the great community engagement. I see Emmanuel Drabo has also posted a question in the chat. Maybe Kelly, you can respond in the chat while we're turning to Ann Weicker from the JHAITC to share a little bit about the this other aligned center and the work that you are doing.
Thank you for that. So I just want to make sure you can see my screen okay. Great. As Kelly mentioned, she has also received funding from our program, which is entering its 4th year here at Johns Hopkins. So we're a little bit behind the HEADS program. I was brought on board as the research program manager at the beginning of this initiative, and it is a cross-university initiative. So we at School of Medicine are working really closely with the Whiting School of Engineering. And this is just a visual that we often use to give a summary of the mission of the AITC. So we're really looking at how artificial intelligence and technology can be used to assist older adults who have dementia and AD-related dementia, as well as how we can just generally help older adults with their healthy aging. So there's 2 pilot cores in this program, one for the ADRD and one for healthy aging pilots. And this is an overview of our full team. You can see that we have PIs from School of Medicine as well as from the Whiting School and the Carey Business School and the School of Nursing. So I like to tell people my job is to just continue building bridges across the university to get everyone in communication with each other for this initiative. And this is just a brief image that kind of shows all of the outreach of the AITC, the other programs that we try to connect with, the resources at Whiting, and when I say resources, I mean that these are available not only to our awardees, but even to the applicants. Our website lists a lot of links that help outside applicants understand all of the opportunities here at the university. So even if our own program doesn't directly offer these consulting services, we do our best to connect our incoming applicants with other resources available here at Johns Hopkins. And obviously these are sort of detailed descriptions of what our applicants might be interested in utilizing. This program was set up to also fund small companies on pilot projects, which makes it somewhat unique as an NIA program. My own background is as a small business owner. So when I came into this position, I can empathize with the small company recipients of these grants who view the massive university infrastructure as overwhelming and intimidating. So we've done a lot in the last 2 years to try to streamline the subaward agreement process for small business owners. And I think we've come a long way. We used to say in the first year that we were building the plane as we were flying, but now I feel like it's a little safer plane. And then this kind of details the funding opportunities. So we definitely have more money in the pilot A core. We give out about $1 million a year. There's a $200,000 max on directs. Generally, we fund about 5 or 6 pilots in core A every year. And then we also fund through core B. We have a max of $475,000 to give out each year. And we usually try to award at least 3, sometimes 4 pilots within that core. Each of the pilot cores has a mentor. Kelly mentioned earlier Esther O. She's the mentor of Pilot Core A, and Dr. Jeremy Walston mentors the Pilot Core B projects. And these are some examples of what we've funded over the last several years. So as I said earlier, we're going into grant year 4. And in the last 3 years, we have funded over 30 different pilots. I have not listed all of them here, but I've tried to give you just a sampling to show that we do fund, obviously, researchers from our university. We fund researchers from other universities, and we fund small companies. And you see several of the logos here as well. In the first year, we were offered the opportunity to provide supplemental awards. So even after we had selected our finalists, we were then able to go to the next highest scoring AD pilots and offer them an opportunity to do a supplemental request. So in that first year, we had, I think, almost 15 pilots awarded. And the same thing is actually probably going to happen now in grant year 3. We were just told that there is another opportunity for supplemental funds. So we're reaching out to additional pilots who received high scores during the review process, but weren't initially selected. So this kind of increases the pilot pool significantly. And I should mention that we work really closely with a coordinating center that's based in Rockville, Maryland. They have been tasked with keeping Johns Hopkins, UMass, and UPenn in communication with each other. UMass and UPenn also received this P30 grant. So they have their own AITC programs, which are a little bit different from ours. UMass tends to focus on at-home pilot proposals. And then here at Hopkins, a lot of ours are within clinic and at home. So each of us has our own kind of individual characteristics, but we collaborate and communicate through the coordinating center. And it's actually the coordinating center that posts the platform our application is on. When you see in the top left corner of that screenshot, the A2 collective, that's the term that refers to the 3 centers plus the coordinating center. And this is text from the site of the coordinating center, just giving a description of the pilot competition opportunity. The process in place now is that a preliminary application is submitted. In our Hopkins AITC, those are reviewed by 1 engineer and 1 geriatrician, and then we select several of those to progress to formal application. And at that point, we also conduct interviews with each of the selected applicants in order to sort of detail and finesse their proposal. We make our final recommendation of funding on about 10 pilots each year, and then the NIAPO is the one who actually confirms the funding. So here are the 3 centers and the coordinating center. And then here are the key dates as they pertain to this grant cycle. So next Tuesday, we're accepting the preliminary applications. There was a Q&A held in March, and there's a recording of that on the Coordinating Center's website. The applications that are invited to submit for formal application have a deadline of April 30th, and then we're hoping to announce in early September with confirmation of funding occurring later this fall. And this is the small print. And new this year, I just want to add one more point. We are really interested in applications regarding biology and AI. So this is something that came down from the NIA as an additional focus for the grant year for pilot competition. And there are details about that both on our own Johns Hopkins AITC website as well as the website of the Coordinating Center.
Wonderful. Well, thank you for that really wonderful overview of the AITC, which I've heard a lot about, but have not been able to really fully understand the structure and the processes that are in place. I think, some folks who are here may be interested, but may not have had time to fully process the information that you've shared. But I'm sure sort of having an understanding may be helpful for thinking about next steps in terms of putting together a pilot proposal. So actually it looks like we're almost on the hour. So are there any questions for Anne? And if not, then there is no problem ending early. I'm sure sure folks can take back a few minutes before the 1 o'clock hour. Hearing none, Anne, I'll just thank you for coming and sharing about the AITC, and Kelly for presenting on your important work that bridges the two centers. We are really happy that that we've have this shared experience of funding your work. And I guess I'll just end by finishing up making a plug for next month's seminar, where we'll be hearing from Frank Zhu and Jamie Smith, May 15th at noon. And Chase has already beat me to it. Great. Thanks, everyone.